Thank you very much, Dr. Ehtesham, for inviting me for this online lecture. I'm Dr. Atif Naveed. I'm a consultant radiologist at Shaukat Khanum Hospital. I did my American boards in radiology and neuro-radiology, and I came back to Pakistan in 2017. And since then, I'm been practicing in Shaukat Khanum Hospital. And it's been a pleasure and honor to be in this forum, and thank you very much. So today I'll talk about MR imaging of multiple sclerosis. As we were earlier talking about that multiple sclerosis is underdiagnosed in our country, in our region. And it's because from imaging point of view, there are many mimics which can look like multiple sclerosis. Many diseases can look like that on MR imaging. And also there is specific criteria for diagnosing multiple sclerosis. So that's why it's very important to find a correct diagnosis for multiple sclerosis. And today I'll talk about MR imaging of multiple sclerosis. I have no financial disclosure. And I'll start with the verse of Quran. A'udhu billahi minash shaitanir rajeem. Bismillahir rahmanir rahim. وَمَنْ أَعْرَضَ عَنْ ذِكْرِي فَإِنَّ لَهُ مَعِيشَةً ضَنْكًا وَنَحْشُرُهُ يَوْمَ الْقِيَامَةِ أَعْمَى. As for the one who turns away from my message, he shall have a straitened life, and we shall raise him blind on the day of judgment. So I used basically neuroimaging clinics of North America articles, and especially the issue that came up in 2017 for the images and some relative information. And I will talk about in the beginning about the basics of MS, what we know about MS, and then I'll talk about the MR imaging of MS in detail, and then I'll also talk about some other diseases which can look like MS on imaging, and then future of MR imaging in MS. So starting with the basics, definition of MS is it is a chronic inflammatory disorder of CNS which leads to demyelination and which leads to long-term disability. And it's a disease of young age group between 20 and 40 years of age, and predominantly in female population. And global prevalence of MS is about 33 per 10,000, and it can be up to 150 per 10,000 in endemic areas where it is more common, especially Northern Europe and Northern North America. And it can be up to 3 or 4 per 10,000 in Asian countries and other countries where MS is not that common. So we don't know the exact etiology of MS until now, but we do know some theories are there that there are some genetic predisposition to this disease, and there are some environmental triggers which can lead to this disease. So basic pathology of MS is inflammatory disease. Start with the inflammation that leads to that goes into the CNS through the blood-brain barrier through the venous vessels. That leads to demyelination in the central nervous system, and that leads to neurodegeneration over time. So that's the basic pathology of MS. Patients present with different neurological symptoms, especially related to such as optic nerve. They can have painful or painless vision loss. With related to a cerebral hemisphere, can be hemiparesis or hemihypoesthesia. Related to brainstem or cerebellum, it could be diplopia, vertigo, ataxia, and tremors. Related to spinal cord, these symptoms could be related to paraparesis, hemiparesis, paresthesia, or urinary or fecal sphincter dysfunction. Other clinical manifestation of MS could be painful spasms, dysarthria, dysphagia, ataxia. We already talked about fatigue, cognitive impairment, and depression. So starting with MR imaging of MS, I will just introduce you some basic terms of MRI and how the lesions look like on MRI. Especially the lesions are basically two types lesions in MRI. One is T2 lesion that we see on T2 or FLAIR images that you can see here. This is a sharply circumscribed ovoid shaped lesion which is hyperintense on the FLAIR or T2 variant image. And this is a zoom out image. You can see very clearly that this lesion is ovoid shape with circumscribed borders. And if you compare with the histopathology, this is basically, this plaque is composed of central vein. Around that vein, there are inflammatory cells, and then there is demyelination going on around the CNS in that area. We can see this MS plaque on high resolution, ultra high field, 7 Tesla MRI. It's been proven that the central vein can be seen on this MS plaque, as you can see in this zoomed out image from the literature. And there is a lesion around this venous vessel. So that is basically MS plaque. This is not specific for MS, but most of the MS lesions are shown to have this central vein sign on ultra high field MR imaging. And the other lesion is gadolinium enhancing lesion, which is also seen on post-contrast T1 varied images. And their time duration is usually, they are seen from 3 weeks to 3 months time. If they are seen beyond 3 months, then we should think about other differentials. And these are due to blood-brain barrier breakdown, so that the gadolinium can cross the interstitium and go into the CNS. And these lesions can be nodular. They can show like rim enhancement, or they can be like incomplete rim enhancement also. So different morphologies are documented in literature about the enhancement pattern of these lesions. So these lesions, these T2 lesion and gadolinium enhancing lesions will be important when we will talk about the MS diagnostic criteria later on in slides. Here you can see this is gadolinium enhancing lesion. So another concept about MS diagnosis is dissemination in time. Like, for example, if we have a lesion in the brain, such as here, and we have a lesion which is showing enhancement. If we do a follow-up and we see another lesion, another development of another T2 lesion or enhancing lesion after some time, so that is called as dissemination in time, that these lesions are growing in size, or they are newly developing lesions over time. Similarly, dissemination in space is another concept that is important. Like these lesions are scattered in the CNS in different locations. For example, here it is in the juxtacortical white matter, here it is in the perivertical white matter, and here it is in the spinal cord. So this dissemination in time and space concept is important to understand the diagnostic criteria later on, and I'll talk about in the next few slides, inshallah. So another concept about MS is pathology is the clinically isolated syndrome. And neurologists know better than radiologists about this syndrome. Basically, this is first clinical manifestation of disease, and it is isolated in time, and it is not preceded by any neurological event. And another definition could be a single neurological symptom, but not fulfilling the dissemination in time and dissemination in space criteria, that is McDonald criteria. So that is a clinically isolated syndrome, or CIS. So in patients with CIS, what is the risk of development of MS later in the time? 80% with MR imaging features typical for MS will develop MS later on, or only 10 to 20% if MRI is normal at the time of CIS. CIS not fulfilling the DIS or DIT criteria, or with spinal cord symptoms, spine imaging should always be performed. Until now, we don't have any specific test available in the market to prove MS as a diagnosis. So that's why we use diagnostic criteria. And MRI is very helpful in making that diagnosis other than clinical evaluation. MRI is very sensitive, 97% sensitive to pick up those lesions with patients with symptoms. And MRI is also very helpful in evaluation for other pathologies that can look like MS on imaging. MRI is helpful in evaluation for disease progression, especially when patient is on treatment. And there is another term called as clinical radiological paradox in MS. It means that sometimes the clinical symptoms of the patient and radiological imaging doesn't match. So sometimes they don't have same findings as we see in clinical examination or we see in MRI. So that is called as clinical radiological paradox in MS. We will discuss later on in the slides. So diagnostic criteria should only be applied when the patient presents with typical CIS symptoms. Other pathologies should always be ruled out. And until now, diagnosis of MS is a diagnosis of exclusion. So in 2010, there was an upgrade in the McDonald criteria, and MR imaging was incorporated in that criteria. And the diagnosis of MS could be made on MR imaging along with associated clinical symptoms. And they rely on, again, dissemination in time and dissemination in space criteria. So what is that criteria? For dissemination in time, there is a new T2 lesion on follow or new gadolinium enhancing lesion on follow with reference to a baseline scan, irrespective of timing of the MR imaging, or simultaneous presence of gadolinium enhancing lesion or non-enhancing T2 lesion at any time. So it can be diagnosed on a single MRI imaging in which gadolinium enhancing lesion is present as well as T2 lesions are present, as long as dissemination space criteria is fulfilled. So what is a criteria for dissemination in space? Is one T2 lesion in at least two of the following central nervous system areas, such as periventricular region, juxtacortical region, infratentorial, including brainstem and cerebellum, and spinal cord. We'll talk about these in details in later slides. So what other pathologies should be ruled out before we can come to a conclusion of MS as a diagnosis? Like such as inflammatory pathologies such of CNS, such as ADAM, which is a grade mimicker, neuromyelitis optica, transosmolylitis in the spinal cord especially, Suzak syndrome, or vasculitis. Other systemic inflammatory pathologies with CNS involvement such as sarcoidosis, Behçet's disease, Sjogren's syndrome, SLE, non-inflammatory pathology of CNS such as CADASIL, leukodystrophies, HIV, or other hereditary syndromes. Natural history of disease is that if you look at this slide, the first triangle is basically CIS. The symptoms developed and then they resolve. But if they later on again develop symptoms, it will be, if it is diagnosed as MS, it will be relapsing remitting MS with subsequent complete remission, and then again another attack in time, and then resolution, complete resolution. And sometimes the symptom doesn't resolve completely, and gradually the symptoms worse over time. That is called a secondary progressive MS. Or it can be primary progressive MS since the very start of the diagnosis. Patient keep on deteriorating over time with symptoms like cognitive symptom and other symptoms. That is called as primary progressive. So that is the natural history of the disease that we see in our patient population. After 20 years, 80% patients will have progressive disease anyway, according to the literature. Another term is also worth mentioning here is radiologic isolated syndrome. These are asymptomatic lesions in the brain or spinal cord in healthy individuals, which are picked up incidentally for some other, for imaging for some other reason. And they fulfill the criteria for DIS, and there is no other explanation to prove these lesions. And 1/3 of these patients will have first clinical event in first 5 years after radiologic isolated syndrome. So basically, radiologic isolated syndrome is brain MRI findings with no clinical symptoms, but that fulfills the criteria for DIS, and then these patients will keep 1/3 of these patients will develop MS down in 5 years. So now MR imaging of MS in detail. So what kind of protocol we should be using, or what we use in our institution, is we use 1.5 or 3 Tesla MRI. So again, I will say here that in Pakistan, most MRI machines in market are less than 1.5 Tesla, like 0.3 Tesla, 0.5 Tesla. So the recommendation and guidelines are basically 1.5 Tesla or higher field strength for MRI, because when we go down in the field strength, the spatial resolution decreases, and also the conspicuity of the lesions also decreased. So many lesions may be missed when we scan on 0.3 Tesla or 0.5 Tesla. Spatial resolution should be at least 3 mm so that we can easily see the lesions on the brain. Some institutions do use DWI imaging, diffuse varied imaging, as we do, and contrast should be used for picking up gadolinium enhancing lesions. And there are some special sequences for gray matter lesions only. So we'll talk about that in detail. So this is the T2 varied image that is part of the standard protocol for MS. This is a FLAIR image that is also part of standard protocol. And this is a post-gadolinium T1 varied images as axial images for MS diagnosis. And this is diffuse varied images that we use in our institution, B1000 ADC maps to look for other pathologies such as stroke, ischemia. And T2 varied images or FLAIR images can be performed in sagittal sequence to look for periventricular or juxtacortical lesions, especially pericallosal lesions. We also use coronal FLAIR in our institution to increase our sensitivity and specificity for these lesions. And there is a special protocol for spine also, for spine imaging. Why spine imaging is important? Because it increases the sensitivity to pick up the MS plaques, and it will also help us to evaluate for other pathologies such as NMO or vasculitis, because vasculitis doesn't involve the spine. Similarly, NMO has long segment involvement of the spinal cord. And it also helps us to predict the conversion of clinical definite MS in RIS and CIS patients. So we use sagittal T1 varied image, sagittal T2 varied images, and stir image in the sagittal plane, and axial T1 and T2 varied images to include cervical spine and thoracic spine. We don't use lumbar spine because spinal cord finishes at L1, L2 level usually. And now we'll just talk about gray matter pathology. So there are some cortical lesions which are only seen in cortical gray matter, and that actually predict the cognition level of the patient. These lesions are divided in the literature, such as type 1 juxtacortical lesions, which are more close to the juxtacortical white matter. Type 3 is sub-PL cortical lesion, which are on the other side of the cortex. And there are some type 2 is pure intercortical lesions, which are in the gray matter. And they do not touch the border of the gray matter. And this is again case from the literature showing high resolution detail that we can see on 7 Tesla MRI, and we can see this juxtacortical white matter, the gray matter lesion that is just touching the white matter. So you can see how much detail we can get from ultra high field MRI like 7 Tesla. This is a double inversion recovery sequence. So we also use a double inversion recovery sequence in our institution, but we have 1.5 Tesla. So you can compare easily like how much detail we can get from 7 Tesla. Again, 1.5 Tesla is still helpful to pick up these lesions in the cortex. Gray matter pathology leads to ultimately brain atrophy. And how that happens, basically axonal loss happens due to demyelination and chronic neurodegeneration. And that leads to brain tissue loss, that is irreversible neurological damage. And this is the final outcome of long-standing inflammatory damage to myelin. And it determines the cognition and physical disability of the patient, brain atrophy. And but the method to estimate the brain atrophy is not in clinical use these days. There are many researches going on how to volumetrically analyze the brain volume, but still they're not in clinical use right now. But usually as a neuro-radiologist, we just look at the brain and we see over a period of time how much atrophy is present, and we just report as that atrophy is present or not present, but we don't quantify it until now. So switching gears to spinal cord pathology. So spinal cord also show focal lesions in MS. So, and these lesions are, if you see here, they are not long segment, they are short segments. Like usually they span one segment, vertebral body segment, or two vertebral body segment. There are multiple lesions. And the other thing is about these lesions are these lesions are more easily picked up on stir images than T2 vivid images. Because stir image, there is a suppression of fat. So that makes conspicuity of the spinal cord more easy. And these lesions can be easily picked up on stir images. But these lesions can also be seen on T2 vivid images also. And ideally, you should see these lesions on both axial and sagittal planes. On axial planes, these lesions are eccentrically located in the spinal cord, and they can involve white matter and gray matter both. Such as this lesion, you can see it is involving the posterior spinal cord eccentric lesion. It's involving the gray matter and white matter both. Here you can see this lesion. These are the multiple small segment lesions, short segment lesions in the spinal cord. And then we can also find diffuse abnormality later in the disease, which is indicative of progressive disease. And we can also see atrophy in the spinal cord, such as here you can see that the cervical spinal cord, ideally it should be more thicker or more should have more diameter than the thoracic spinal cord because of nerve roots coming out. But here you can see that there is significant atrophy of the cervical spinal cord here as compared to the thoracic spinal cord. So this atrophy means that there is a long-standing disease going on. So I'll show you a case of a 43 years old male who has a known history of pituitary microadenoma, and he had a surgery in 2018, and he had acute symptom of right arm weakness. So this is MR imaging in December 2021 that showed this periventricular lesion on the flare coronal image. You can see that again, another lesion on the right, periventricular white matter, perpendicular orientation. Another lesion in the periventricular white matter, you can see with ovoid and sharp circumscribed margins. This patient also had another juxtacortical lesion in the right temporal lobe that we picked up on the coronal scan. This patient had no diffusion restriction in the center of this lesion. This lesion was T2 hyperintense in the periventricular white matter. And also you can see that this is showing incomplete rim enhancement. So incomplete rim enhancement is typical for demyelinating disease. And you can see that this deficiency of rim enhancement at the site of ventricles. Follow-up of this patient showed in next month showed new periventricular lesions in the left periventricular white matter, which are also showing gadolinium enhancement. So again, if we apply McDonald criteria with dissemination in time and space, so this is dissemination in time because in follow-up we have a new T2 lesion and we have a new gadolinium enhancing lesion. Even at the time of first image, we also had a simultaneous presence of T2 lesion as well as enhancing lesion. So dissemination in time criteria has been fulfilled here, and dissemination in space criteria has also been fulfilled by lesions in the periventricular white matter and in the juxtacortical white matter, such as this lesion. You can see this is in the juxtacortical white matter in the right frontal lobe. So we sign out this case as symptoms typical for MS in correct clinical settings. So other diseases which can mimic MS. It is why it is important to know about these other diseases, because long-term disease modifying therapy, it is very costly and it is a long therapy. So it is essential to exclude conditions that can resemble MS. So correct diagnosis is very important. And I will talk about these, at least these syndromes and these diseases in this particular presentation, because I cannot talk about all these pathologies in this one presentation. Um, but still we can discuss some of these diseases. So we have a case of 11 years old boy with non-metastatic uvein sarcoma, 16 months post-treatment, and he was transferred to ICU with generalized tonic-clonic seizure and encephalopathy and decreased GCS. And he had fevers for 2 weeks and leukocytosis. So this is a FLAIR image in axial plane showing multiple patchy white matter disease in both cerebral hemispheres involving the deep gray matter, involving the subcortical white matter, involving the U fibers. And these are like patchy, asymmetric disease involving predominantly the white matter. So we give a differential of ADEM in this particular case, given the history and given the presentation of the patient and with these imaging findings. And this patient had CSF analysis which showed high proteins, and his EEG at that time showed severe encephalopathy in delta range. And he was started on methylprednisolone IVIG therapy after consultation with neurology. And then after 2 weeks, his EEG and his symptoms improved. Later on, suggesting the diagnosis of ADEM. Although we don't have follow-up imaging to confirm that these lesions are resolved. So that is, again, I will show you today these cases, that how proper imaging and guidelines can help us to correctly diagnose these things, and how we are not doing it in our routine practice. So ADEM is basically a disease of white matter. It doesn't have any radiological features that completely characterize ADEM lesions. Encephalopathy cannot be explained by fever in ADEM, and T1 hypointense lesion should not be observed in ADEM patients. That is typical for MS, T1 hypointense lesions. And follow-up imaging is recommended to exclude dissemination in time. As I told you that in this particular case, follow-up imaging was not performed. I checked the system, our hospital system, and no new lesion should develop over time. That is also important for ADEM as a diagnosis. ADEM lesions should go away in a follow-up examination. Next case is a 35 years old male with complaint of bilateral blurring of vision since 2 months. Left eye was affected 1 month prior to right eye. This patient had chronic spastic weakness of bilateral lower extremities with bowel and bladder incontinence since 2010. And somebody did spinal surgery in 2013 as well for these symptoms. And he had no history of trauma. So these are his MR images of the orbits. You can see here there is a significant atrophy of the right optic nerve. You can barely see the normal optic nerve on the right side. Similarly, he has also significant atrophy of the left optic nerve also. And you can see on the coronal FLAIR image that it's like thin paper-like optic nerve on the left side and on the right side. So the patient has bilateral optic nerve atrophy that is suggestive of chronic long-standing disease involving the optic nerves. This patient also had in MR imaging some subappendible lesions involving the right caudate nucleus and right anterior putamen. You can see here T1 hypointense lesion and T2 hypointense lesion, not showing contrast enhancement. And the other lesions in the brain, they are not fulfilling the dissemination in space criteria in this patient. And on the spinal cord imaging, we see a long segment lesion involving the entire spinal cord, lower thoracic spinal cord. And we see this lesion spanning the whole diameter of the spinal cord on the axial plane. And we see some post-surgical change in the upper thoracic spine due to previous surgery. So this is classic for NMO, neuromyelitis optica, with atrophy of the bilateral optic nerves and long lesions in the spinal cord and very atypical lesions in the brain. So we signed out as demyelinating disease suggestive of neuromyelitis optica. We suggest clinical evaluation and further confirmation with antibody serology against anti-aquaporin receptors. Another similar case of 27 years old female with history of headache, vomiting, and nausea. So she was in one of the remote diagnostic centers. So we see a T2 hyperintense lesion in the brainstem here in the medulla oblongata. So this lesion was also involving the right corticospinal tract and right thalamus here, and in the left cerebral peduncle we can see this lesion, and then we see the area postrema of the brainstem. So again, we signed out as a demyelinating disease with typical findings suggestive of neuromyelitis optica because of involvement of the area postrema that is classic for NMO, and cerebral peduncle and corticospinal tract. NMO is basically another demyelinating disease which has different pathology than MS. Basically, these are autoantibodies against aquaporin 4 receptors, and this leads to massive astrocyte destruction. Why it is important to diagnose it correctly? Because the drugs for MS such as interferon or natalizumab or fingolimod can aggravate symptoms in these patients if we don't correctly identify them. In optic neuritis, it will be bilateral and extensive optic neuritis, as in our case, in anti-aquaporin 4 antibody NMO syndrome. And these lesions are long lesions. They show contrast enhancement, and they can, in acute settings, they can present with swelling of the optic nerves. And then they can lead to long segment atrophy, as we see in our case. In spinal cord, they can present with transverse myelitis or acute myelitis, and they involve, by definition, they should involve more than 3 segments of the spinal cord. They can lead to cord edema and later on, subsequently, cord atrophy over time. And length of the lesion is correlating with the disability of the patient in the spinal cord. Brain lesions are not typical for MS, and they are usually in the periependymal white matter, such as in our case, around the ventricles area postrema in the brainstem. That's why these patients can present with nausea, vomiting, and they are usually involving the corticospinal tract, cerebral peduncle, and cerebellar peduncles. There is another subset of disease called as anti-MOG antibody seropositive NMO disorder, because these patients are negative for anti-aquaporin antibodies, but these are positive for anti-myelin oligodendrocyte glycoprotein antibodies. These are only 10% of the NMO patients who are basically seronegative to anti-aquaporin antibodies. There is some overlap in MR features, but predominantly this is kind of milder disease, which shows some inflammatory demyelinating disease on imaging. These patients' anti-MOG antibody syndrome can also have optic neuritis, but these lesions are not very long and they don't lead to atrophy of the optic nerves down in the disease. And these in the brain, these lesions are usually around the ventricle, third ventricle, in the diencephalon, involving the hypothalamus and thalamus, and the limbic system, including cingulate gyrus and hippocampal region. This is a case from literature showing involvement of the cingulate gyrus. You can see the T2 hyperintense lesion in the cingulate gyrus, here in the cingulate gyrus involving the corpus callosum, and pulminar of the thalamus here, and along the third ventricle area. Another case is a 58 years old female with headache off and on. She complained of right side weakness leading to complete loss of motor power in the right arm and leg for 12 days, and with sparing of the face. She had labs in December 2021 showed an elevated endocardiolipin antibodies. ESR was elevated, IgG and IgGA was negative, and patient presented with leukocytosis. She was not diabetic, but she was hypertensive. So this is a MR image, a diffuse images showing hyperintense lesion in the left internal capsule, right caudate nucleus, and left basal ganglia. So suggestive of acute infarcts. And there are some on the FLAIR images. There are multiple other lesions which are in the deep white matter, the subcortical white matter, which are not fulfilling the criteria for DIS for MS. And in the same scan, when we saw down in the skull base, we came across with the parotid gland, and we saw these multiple lesions in the parotid gland, hyperintense lesion, and we suggested that this could be Sjogren's syndrome because of bilateral involvement of the parotid glands. And the patient was known to have Sjogren's syndrome that we later revealed by going through his chart in the hospital medical record system. Another important syndrome to know is Suzak syndrome. Usually, it is in the literature, it is defined by triad of encephalopathy and branch retinal artery occlusion and hearing loss. But we seldom see this in our real life. All these three symptoms and presentation at in the same patient. So we have to be careful when we look at the MR imaging of these patients because these patients will have multifocal infarcts in the brain, and they have central callosal lesion. Like this is very important to differentiate from MS because MS patients can also have pericallosal lesions, and they also can have lesions in the septocallosal interface. But these lesions, on the other hand, are in the central of the corpus callosum, and they have long tract involvement, such as in the posterior limb of the internal capsule. Here you can see there is a lesion within the corpus callosum, which is in the center of the corpus callosum, involving the entire width of the corpus callosum in the genu, in the body, and in the posterior body. And then there is a long lesion in the posterior limb of the internal capsule here. Another important disease that we see every day in especially old patients population, especially with risk factors of hypertension and diabetes, vascular lesion, small vessel ischemic disease. These lesions are in the brain and the cerebral hemispheres, as well in the deep gray matter, as well as in the brainstem. So important differentiation feature is when you see lesion in the brainstem, the demyelinating diseases, usually they involve the peripheral part of the brainstem. But on the other hand, these vascular lesions, they involve the central part of the brainstem. Similarly, vascular disease does not involve the corpus callosum, does not involve the spinal cord or temporal lobes. They spare the subcortical U fibers as opposed to ADAM, MS, or other diseases, demyelinating diseases, and they show no contrast enhancement. Next case is 23 years old female with complaint of headache, seizure, left side weakness for 2 years. And outside she was diagnosed with glioma, and now she has left-sided residual weakness, and she is recovering from that weakness. So this is again MR image, an axial plane, FLAIR image showing diffuse cortical atrophy, dilation of the sulci, and you can see that there is involvement of the temporal lobes bilaterally, involving the subcortical U fibers, involvement of the external capsule area, and the frontal lobe area. So this was only like 23 years old. So we signed out as demyelinating disease or vascular disease such as CADASIL, including in the differential, because there is involvement of the anterior temporal lobe, inferior frontal lobe, and external capsule by definition for CADASIL. Again, this needs further evaluation with genetic marker and the gene mutation that is diagnostic criteria for CADASIL. But on imaging, this was quite consistent with CADASIL because there was also U fiber involvement, and corpus callosum, cerebellum, and periventricular regions are usually spared in this disease. Next case is 46 years old female with 1.5 years history of gradually decreasing vision, rapidly worsening over 1 week. And somebody in outside hospital, they diagnosed this patient as optic chiasm glioma. So this is MR image showing, we can see the FLAIR image on the left side. There is a hyperintense lesion, not only within the optic chiasm, but also in the pituitary area or hypothalamic area. And these lesions are showing contrast enhancement on the axial plane as well as on the sagittal plane. So you can see that there is thickening of the infundibulum. There's a lot of junk in the enhancement in the hypothalamic region, third ventricular region, and in the suprasellar region. You can see that. Again, coronal image is showing more of this enhancement in the infundibulum, optic chiasm, as well as in the hypothalamic region. This patient also had leptomeningeal disease on the surface of the brain. And then we also had X-ray in our system, and then we found that the patient has bilateral hilar lymphadenopathy. So we gave a differential of neurocytosis in this particular patient because of involvement of the meninges, hypothalamic and pituitary lesions. So this is another important mimic of MS that should be considered when we have MRI images and typical symptoms for these diseases. So now I'll talk briefly about the disease-modifying drugs. As my neurologist colleague will know better than me, like there are multiple drugs available in the market which are used for treating for multiple sclerosis. There's a long list. And why it is important to have MRI in these patients, because we can have evaluation for these patients, whether these patients are responding to treatment or they are not responding to treatment. So protocol is basically just to have image when you start these medications and then have a yearly follow-up. And MRI is better than clinical evaluation because MRI can pick up a lesion which is not symptomatic at that time. And it can give you an idea like how much disease is still not responding to or responding to the treatment. So any new pituitary lesion or enlarging pituitary lesion is not a good sign. Similarly, any new contrast enhancing lesion is not a good sign when patients are on these drugs. And especially there is a risk of PML from JC virus in patients who are treating with natalizumab. So that is another important reason to have MRI imaging. So baseline MRI imaging has a prognostic value because if the lesion load is too much, these lesions will may do not better, may do less than the patients who have less lesion load in the beginning. And it's not only on the top of that, not only the number of lesions are important, but also the topography of the lesion is also important, because if lesion is in the brainstem or in the spinal cord, will have more symptoms as compared to lesion in the periventricular white matter. So especially it has been shown in literature that a large number of spinal lesion at baseline predicts poor outcome. And the disease-modifying drugs have shown significant and sustained reduction in degree of this increase in lesion load and lesion increase in size. Why MRI imaging is important again, because current immunomodulatory treatments are only partially effective. So detection of any active lesion in the follow-up is important. And there is insufficient evidence to establish a minimum number of T2 lesions that can confer a poor long-term prognosis. So we don't know exactly at this time how much lesions should be present in the baseline imaging scan to predict the poor outcome. So now a couple of slides regarding the future of MR imaging in multiple sclerosis is that we have right now 7 Tesla MRI available in multiple tertiary care hospitals in US and Europe. And these are basically for research purpose, not for clinical purpose at this time, especially not in our country either. But 7 Tesla MRI gives a very high spatial resolution for picking up these very small T2 lesions or enhancing lesions in the brain. And you can compare on this image that the 1.5 Tesla MR, you can hardly see any lesion, especially the great white interface is not very sharp, not very crystal clear. But on the 7 Tesla, you can see so much detail. You can pick up small lesion very easily, as shown in these red and blue arrows. Similarly, we can apply multiple other sequences like T2 star weighted images to pick up these cortical lesions, which are not easily picked up on recent MR imaging, because cortical lesions are also shown to correlate with the cognitive impairment as well as physical disability of these patients. So picking up cortical lesions are also very important. And this ultra-high field MR can promise for picking up these lesions, as seen in this case. You can see this T1 weighted images and showing this cortical lesion along the central sulcus on the left side, this T2 SAR weighted image. Another technique of MR imaging, T2 star weighted imaging and phase contrast reading echo imaging, showing multiple lesions in the brain, which will hardly able to pick up on 1.5 Tesla. But again, these ultra high field MRI is not still available in Pakistan for clinical use. So thank you very much. I will conclude my talk, and I will invite questions if there is any question.
Sure. Thank you, Dr. Atif. It was a great talk, and I learned a lot. I do have some questions which I believe the listeners would have as well. Okay, thank you very much. So starting with, you mentioned about 1.5 or 3 Tesla MRI for imaging of multiple sclerosis patient. So I know most of the market has below 1.5 Tesla. So I think I would like to stress the point regarding patients where there is suspicion for multiple sclerosis, that they should be referred to centers where there is availability of at least 1.5 Tesla imaging, and the special sequences should be used to pick up the abnormality, because otherwise there's a good possibility that you may miss the diagnosis, and that delay in diagnosis means more burden of the disease over the period of time, as you have shown in your slides as well. So what do you think would be the scenario if we do repeated MRIs with contrast in these patients? What complications you think of could be seen in patients? Because multiple sclerosis patients, in case of relapses, when there is concern for progression of the disease, physicians tend to do repeated MRI. But what would be the side effects of repeated MRI with contrast?
Basically, MRI is quite safe modality. So far, no major side effect or major adverse effect has been documented, because there is no ionization radiation as compared to CT scan or X-rays. Number one. The only thing is like a little bit uncomfortable for the patient, because of some patient has claustrophobia. Some patient may not lie flat without motion in the MRI magnet for half an hour or so. And there could be some reactions to contrast from gadolinium also, especially in patients who have predisposition to allergic reactions, or patient who might have renal problems may not get gadolinium anyway. So these are some of the precautions or some of the features which can occur during repeat MRI imaging. But again, if patient had one MRI, he should or she should be familiar with how this examination is. And I'm sure that they may not be claustrophobic because they have experienced one MRI. So it should not be a big problem. But I think, as I mentioned to you, that yearly follow-up MRI is enough in MS patient, unless there is a relapse, as you suggested.
Sure. And there could be possibility of retroperitoneal fibrosis with repeated contrast in a small population of patients, which is
especially yes, especially in patients who have renal failure or renal compromise.
Right.
NSF is a known diagnosis.
Great. You've mentioned stir imaging. We do stir imaging in spine cases. And as you've shown that the patients who are having T2 weighted images, the lesion doesn't show up. Yes, it is there, but it is not that obvious what we see with the stir images. So first, let the audience know what does STIR stands for, because there are a lot of abbreviations in radiology, and what this special sequence holds for when it comes to spinal imaging.
Okay. So STIR stands for short tau inversion recovery sequence. So basically, this is an inversion recovery sequence in which we null out fat in the body and we just rely on the other signals to develop. For example, fluid or spinal cord, as you said. So the difference between STIR image and T2 weight images is that the fat is stressed on STIR image. So that really make any lesion in the spinal cord come out. It will like blow to you, like you can see very well that lesion in the spinal cord. And ideally, both sequences should be performed for spinal cord imaging, because STED image can sometimes pick up lesion which may not be easily seen on T2-weight image. And especially in demyelinating disease, it is very important. And we do in our institution also. And it's recommended in, I think, guidelines also to do STED image.
So the patients, again, where we suspect that patient had multiple sclerosis, that there is suspicion for multiple sclerosis, should be sent to a place where there is STIR capability or STIR sequences are available. In other words, it's just like the FLAIR images of the brain, where we allowed the fluids. You nicely mentioned about the black holes. And that is a very important point when we talk about the MS imaging, because that also a prognostic factor and points towards poor prognosis of patients, because those patients who have black holes in the brain on imaging, they tend to do poorly in terms of MS progression. One more thing with respect to T2 star or GRE imaging, because there is another sequence called susceptibility weighted images, SWI. Do you think that will give a better idea, especially when we don't have higher Tesla imaging available in the country, that SWI could give us a better idea about the cortical lesions, like the way you have shown on GRE?
Yeah, your question is very good, actually. I would say that on 1.5 Tesla or 3 Tesla, SWI may miss some lesions in the gray matter because the resolution is not very high. But as I have shown you in the literature, that 7 Tesla MRI, when we go to higher, these lesions conspicuity becomes very prominent. And there are some special sequences like susceptibility weighted images, which has very high sensitivity for picking up cortical lesions. We do in our institution double inversion recovery sequence. That is kind of an inversion recovery sequence, but we null twice that CSF and fat. That is used for cortical lesions. But we don't use SWI sequence on 3 Tesla or 1.5 Tesla, and neither there are guidelines to use SWI sequence to picking up cortical lesions in 1.5 or 3 Tesla right now. But I have learned so far.
Sure. No, thank you so much. And one last thing with respect to the type of lesions we see on the MRI, I think there's a size criteria that it has to be more than 3 millimeter or more, ovoid in shape, and the locations or the topography that you have mentioned for the smaller lesions, because like the mimics you have mentioned, and like in migraine patients, there could be smaller white matter lesions. So that could be a mimic in such cases. So the imaging criteria should be fulfilled. And I really like my radiology colleagues who will be seeing this lecture, that they should stick to the criteria when they're reporting, and because over-reporting or under-reporting, both ways the clinicians may be drifted from the original diagnosis. But I think I will also stress upon the physicians as well, that they should do a detailed clinical assessment and then look into the radiological assessment to make a final diagnosis of multiple sclerosis, because there is nothing final. Yes, imaging is very helpful, but it all starts with the history and examination. I really appreciate Dr. Atif for taking time out from your busy schedule, and I believe it's gonna be a great lecture for everyone. Thank you so much.
It's a pleasure. Thank you very much for inviting.